Let me just start. All right, well, it's really great to have you all join us for the session today. We are a community of practice here in East Africa, and this is a teaching session and also case discussion using the Project ECHO model. We've been meeting for the last 10 or 11 months, which is really exciting. We meet on a monthly basis, and we have a group of faculty that have been very committed to the team. And we're really excited today to be speaking about breast cancer in humanitarian settings, as well as integrating palliative care into the work. And we have a few new people on the call today, which is really nice. Usually we have a few others that are able to join as well. We have people from Ethiopia, from Ghana, from Kenya. And I'd love for Ali to introduce himself. He's one of our faculty members, Ali Hamis.
Thank you, Erin. I'm
Oh, we just lost you, Ali. Yeah, go again.
Thank you. I'm from Radab. I'm called. Sorry, I was having a call.
Oh, sorry, you're a busy guy.
Sorry for that. I'm called Ali Abdullahi from Radab.
Yep.
Hi to all of you. Thank you. I work for humanitarian assistance here in the Radab Refugee Camps. I'm a clinician. I'm also one of the faculty members in health in humanitarian setting for palliative care, Project ECHO. Thank you.
Thanks, Ali. Good to have you on the call again today. And I'll introduce Vilma as she'll be presenting the case, but we have a few other faculty members on the call too, so I'd just like them to say hi to everyone. Dr. Zefora Ali, if you have time, you can just
Hello,
say
hi everyone. Hi, sorry, I'll not put my video in. I'm in the village somewhere very far, and connectivity is not so good. But thank you, and I'm looking forward to this session. Thank you, Erin. Thank you, everybody.
Dr. Zippy has been supporting palliative care in Kenya and in the region for many, many years. She's been very involved in our national association here in Kenya and has now shifted over to the Non-Communicable Disease Alliance. And she's chairing that, and she's always an advocate for palliative care, especially in really fragile contexts. So she's been to Dadaab several times now, and she's always a good cheerleader for our group. So thanks for being here with us, even with bad connection. Dr. Omar, I see that you joined us.
Erin.
Can you hear me now? Hello, can you guys hear me? Oh, sorry, the connection was off. Hi, Dr. Omar. I see that you've joined us a bit early. It's great to see you. Just wanted to quickly confirm, would you like to do your teaching now, or are you okay to do it second?
I think I can do it now.
Okay. Okay, perfect. So Dr. Omar, I'd love to introduce you, and then for anyone who's kind of been joining, or this is the first time joining, we'll start today with a lecture on breast cancer in humanitarian settings, integrating palliative care and supportive care into that work. And then we'll have a time for discussion. So if you have any questions for Dr. Omar directly, we'll be able to set aside some time for that. You can put it in the chat. Myself and Vilma and Ali will be looking at the chat the whole time. And then we'll end the call today with a case discussion. So Vilma will be sharing a case from Uganda, northern Uganda, and then we'll have time for discussion. So if you're able to stay on for the whole call, that'll be great. We do know that your time is precious. So if you do need to leave, then just send us a message on the chat and we'll connect with you guys again next time. But I'd like to take the time, I guess I didn't introduce myself. My name is Erin. I'm a palliative care nurse currently based in Kenya, and have been supporting palliative care access to education in humanitarian settings with PallCHASE for the last several years, and we're really excited to be able to run this community of practice. So we meet once a month. We have different topics that we talk about, and we also allow for our participants to share cases during the session. So if you are ever interested in sharing a case, please do reach out to me. I'll leave my contact details on the chat, and then you'll have access to our faculty and kind of our group to form a discussion around the case. So I won't take too much more time, but I am really excited to introduce Dr. Omar. Dr. Omar is a clinical oncologist, and he is currently based in Canada, but his home is Garissa, I would say, where he leads the Cancer Center in Kenya. He has been advocating for better access to oncology care for communities that are often neglected. And that's why we're really excited to have him with us today. He'll be able to tell us a little bit more about what he's currently doing, but he has relocated to Canada for about 6 months. And we're really excited for him, but he also has been a very strong cheerleader for our program and our teaching. So welcome back, Dr. Omar. Thanks for joining us. I know it's a bit early in Canada, but it's really good to see you.
Thank you, Erin, for having me. It's a pleasure to join the call. If you may be able to make me a co-host so that I can share my screen.
Perfect.
But while you do that, my name is Omar, as Erin has mentioned. I work at Garissa Cancer Center, and I'm recently doing my cancer research fellowship at Queen's University in Kingston, Canada. This is a very important topic in humanitarian setting, as Erin has said. A lot of people really suffer through this silent disease that, are you able to see my screen?
Yeah.
Awesome. Okay, good. So, so I'll just be doing much of overview of breast cancer and palliative in care in humanitarian setting. Mostly pain management. That's what I want to focus on, and in the setting of metastatic breast cancer, which mostly is probably the locally advanced and metastatic types are mostly the ones we see due to lack of awareness, poor health seeking behavior, and late presentation. So this will be our topic. I won't take much of your time. I'll just be tackling 3 subtopics: models of care, which are very important, and then patient assessment is very important even for that pain and care, and then the common physical pain in breast cancer. That's what we want to focus on. So just a bit of an overview. Breast cancer remains the most common cancer in women and is the leading cause of cancer-related death in women, both in developing and developed regions. Approximately 5 to 10 of all these newly diagnosed cases actually present in metastatic disease, and this could be even higher in our setup. The natural history of breast cancer, as we know, is different. Not all breast cancer is not one disease. We have different subtype of breast cancer. We have those ones that I highlighted in red. There's one called hormone receptor positive. There's another one which is HER2 overexpressed, and there's one that's called triple negative. So the hormone receptor is usually estrogen receptor and progesterone receptor, and the HER2 is just a protein which is on the cell surface of prostate of breast cancer cells that really feed off the growth signal of that breast cancer cells. And triple negative, as the name suggests, it does not have any of the 2 hormone receptor status and does not have HER2 status, so it's called triple negative. So coming closer home, which is what we really need to focus on, we had 42,000 cases, and this is the latest data on 2022. So this is not 2018 Globocan data. This is actually 2022. They usually update after every 2 years, so we don't have the latest 2024 data yet. But you can see the numbers of cancers that were diagnosed, 44,000. Out of that, nearly more than half, deaths with 29,000. If you look at the top most frequent cancers in Kenya, for males, it's usually prostate is number 1, followed by esophagus and rectal or colorectal cancer. When you look at female, it's actually breast, and then followed closely by cervix, and then esophageal cancer. We'll talk about esophageal cancer someday, why it's appearing number 2 in men and number 3 in women. It's really lethal disease as well. But if you look at the overall incidence in both sexes, you see breast cancer is actually the most diagnosed type of cancer in Kenya. But I do believe that maybe not in the distant future, in 5 years, probably esophageal will be the most diagnosed in both sexes. So care has really changed over the years. From COVID, we learned that we do not actually need just to be going to the physical like brick and mortar facilities. You can actually access care through telemedicine, which I hope, one day will be accessible to all our refugee community and patients in humanitarian setting. This is a UICC paper that was talking about how really, cancer care can be improved, especially in the metastatic setting, using, embracing telemedicine for even palliative care purposes. So I hope we get there one day. So let me again now advance to the special needs among breast cancer patients in advanced disease. Okay. So most of my work, I just really got it from this paper led by Nathan Chani, who is a big leader in palliative care. He's an Israeli, medical oncologist who has really done extensive work on palliative care in terms of, how to diagnose it, how to really go about it. But I wanted to look for some data in Kenya because we live in Kenya, and I came across this interesting, a very well-written paper by Ellison et al. And Dr. Hussein Elias, which I happen to know from Moi University, among other, Kenyan authors, including Jacqueline Nyongesa. This really was a retrospective study that really ran for quite a while. You look at that methodologies all the way, chart reviews of patients, to collect their demographic, physical, and symptoms, and specifically for breast cancer. And the conclusion of this paper was the low rate of surgical intervention led to a lot of painful breast wounds, which we're going to talk about. That was a major factor for women seeking hospice admission. So really, sometimes, if you present, if your disease comes at a late stage, if there is probably minimal chance of prolonged survival, at least, good quality of life and painful pain management is really key. And these findings further suggest that our team really, need to maintain expertise in pain and wound management, according to this study, specifically for these, breast cancer cases in rural outreach Kenya. So now I'll talk about the models of care for patients with breast cancer. There's different models. There's the oncologist-based palliative care, where the oncologist takes the lead role in coordinating and caring for, palliative care, drugs, anti-cancer medicine, surgery if needed, radiation therapy, especially in the setting of palliative radiotherapy. Then there's the concurrent model, where both an oncologist and a palliative medicine, really a specialist working in the context of multidisciplinary, is really needed to put all this together. And in my opinion, at Garissa Cancer Center, we really put a great emphasis on these programs to be led by palliative care nurses, and pain management really is asked in every visit of the patient. So how do you assess patient needs for palliative care, especially in the setting of breast cancer? So I think the first thing is just really to start from the bottom. The early establishment of good symptom control, early here, meaning the key word, builds the trust of patients and their families and the facilities, and facilitates the ability to address other important issues. What I'm talking here about is the early assessment of patients for their need, or rather the urgent need for quality of life, improvement services, including palliative care. And this really wraps around, first of all, assessing the patient if they're fit for any intervention. That includes looking at their performance status, their level of function, reflecting on their mobility, ability to communicate, and asking them exactly what really the main pressing pain problem is for them. Their quality of life in terms of their daily bowel movement and bladder function. All these, is very important. ECOG is, a tool that we use, which is more of a performance status. So and then further on, while you're asking all of this, you need to really use the validated tools such as WHO pain scale. There's also the level of alertness scale. There's so many, tools that we can assess our patient to really know their specific needs. And looking at the guidelines, really this is an updated guideline, and I'm seeing Dr. Ziporo is on the call as one of the international co-author of this paper from ASCO. It really talks about primary palliative care provided by oncology clinicians and specialty palliative care. In our setup, probably we're leaning more towards on the left side of the screen, where we need to really implement primary palliative care provided by our facilities. This includes assessment and management of symptoms and physical needs, and assessment and management of psychological or spiritual concerns. There is also need to really integrate cultural-based cancer care, as I like to call it, and really be mindful of the cultural aspects of actually, adhering to such services. Coordination of supportive care services and referrals to specialty palliative care and hospital, and early initiation of such referral is really key. But if you really a tertiary care center where you even have an extra layer of support, then we look at the right side of the care guideline, where there's really enhanced, or maximal space for even initiating a high level of pain management, including epidural block, high level of morphine pump, round the clock pain management, breakthrough pain management, and all that. And the last assessment, we talked about the patient assessment. The second assessment actually is the family assessment. We really know in our African culture, cancer is not a patient disease only, it's a family affair. Okay, so that we really need to understand if the patient really has a good support in terms of their family, who is caring for them. Is the family support even, maybe some patients have only one carer, and is that actually the person are they healthy? Are they able to really step up to the care of this particular patient? And that's why I highlighted concurrent medical problems in family member. Discrepancies between what is known and understood by the patient and their family is really quite important in our setup. You get to see families who tell you, don't tell the diagnosis to the patient, they're going to feel really bad, and they're going to be very stressful. So really striking an important line between these two is very key. And then finally, let's assess the healthcare professionals who are supposed to offer such services. And for this to happen, you need to effectively plan for ongoing care. You need to assess actually if there are people who are qualified and who are trained to offer such palliative care services. The case manager specifically here must understand the limitation of the involved healthcare professionals in terms of lacking knowledge gaps and availability for home care. And then finally, there's difficulty in coping with the situation and the perceived needs to improve care outcome. So we need to really know if there is an expertise in terms of healthcare professional. The specific lead for that particular case, who is the case manager, should make sure there's a steady flow of all the plan. And in case this patient is referred for home care, there should be a coordinated effort for those patients, for those healthcare professionals to follow up the patient for home care. So I've talked about patient assessment, I've talked about family assessment, and I've talked about healthcare assessment. All those are really vital, and the granular details that really leads to the success of palliative care. But now here is the initial pathway of how to go about all this. So the medical condition of a patient and the goals of care should be defined. First of all, do they have breast cancer? Do they have esophageal cancer? You need to know that, and their goals of care. Description of the involved family members and healthcare professionals. This is the family assessment, as I've talked about. Patient issues, psychological, existential, social crisis, and the understanding of their own disease. This is the patient assessment factor. And then the family assessment factor that I talked about, their support. Is there discrepancy between the disease, what actually the patient knows about their disease and what the family knows about the disease? And then there's the healthcare professional assessment, where you see all there are gaps in training, resources, and even there's something called caregiver, burnout sometimes, even the ones who care for this patient. So there's a bit of like matching emotional coping and all that, and how the family and the professionals even who take care of these patients actually cope with this journey. So this is the initial pathway algorithm, which sums up what we talked about in the previous slides. Going further now to the details of really the physical pain that is associated with the breast cancer is very important to know. Overwhelmingly, the most common cause of cancer-related pain in women is actually bone metastasis, leading to all the way to bone fractures and nerve pain, which is as a result of the bone impinging into the nerves. And as you will see in our case, I saw them. Actually, this was entirely with the literature. And the patient had a very presented with bone metastasis. Chest wall infiltration, I really looked for a photo to really look for a black woman with a fungating, and apparently Google could not help me get one. But I think we don't need to be shown that. We really see all this every day in our clinics. You see big fungating and breast cancer, that you actually wonder why this person really did not come to hospital on time. There is also brachial plexopathy. This is a bit technical, but what it means is the brachial plexus runs really lateral to the breast and all the way from the armpit. And the tail of the breast is usually to the armpit. So because there's lymph nodes involved in the armpit area, then they really block the nerve and leading to a lot of numbness all the way to the distal part of the hand. There's headaches as a result of probably brain spread or even emotional stress from the breast cancer. And really, this is also a common presentation for abdominal pain, and patient will never be pointed to as a liver capsular distension, but actually it's probably because of the liver spread. The liver has a capsule, and once it's stretched because of the involvement of the disease, you get a bit of a pain. And all this is really because patient delay, which will because of the delay of the patient coming on time to seek care, or even the patient really came on time, but the system fails them, as we see most of the time, where the system delay describes the time that lapses from consultation to diagnosis. There's another fancy term for that. It's called time toxicity. Time toxicity is the time you get diagnosed to the time you spend doing all these lab works and insurance issues, and you don't get to see the doctor right on time from the time you moved into that institution. So we really need to reduce time toxicity and also financial toxicity, as we say. So coming now to more granularity of those symptoms, you see this back pain and epidural compression, or the so-called cauda equina syndrome. This is very important. As we say, breast cancer likes to go to the bone, and with the bone involvement, the nerves run literally under, like a cauda and ventrally to those bones, and there's compression. So you may see, a posterior extension of the vertebral metastasis to the epidural space, and then it even pinches on the spinal cord. And sometimes this can even lead to paralysis and cord compression. And then there is actually pain that results from the treatment of the disease itself. This is called iatrogenic pain. I did not want to write that technical term because of our audience, so I wanted to make sure this is understood. There is actually a treatment-related chronic pain, okay? And this really looks is a major cause of patient distress, even among patients with an early stage disease. Post-axillary dissection neuropathic pain. You remember I told you guys the tail of the breast is usually in the armpit, and whenever there's a breast cancer, if it's a locally advanced, it also presents with lymph nodes in the nearest axillary region or the armpit area. And when surgery is being done, especially for early breast cancer, what they do is they remove the breast and also they dissect the armpit area to remove those small glands or the so-called lymph nodes. Okay, that actually gives a lot of pain. And remember, I've told you the brachial plexus runs around this area. So there is post-axillary dissection neuropathic pain. Excuse me. And then another treatment-related chronic pain is actually what we call taxane-induced painful peripheral neuropathy. Taxane is a form of chemotherapy drug like paclitaxel and docetaxel. This also leads to a lot of pain because it really results from the post-treatment chemo, because of chemo is needed to even give chemo. Chemo is used usually to give treatment to breast cancer either before surgery or even after surgery. And then you will imagine this drug is innocuous. There is no treatment that doesn't have side effect. This is a aromatase inhibitor drug called letrozole. It's usually given to postmenopausal women who, are hormone receptor positive, to really further, shut down the estrogen signal, which feeds the breast cancer. And this drug really causes a lot of problem. You can imagine a woman who is postmenopausal, already her estrogen reserve is low. With estrogen, there's corrected correlation between bone strength and estrogen reservoir. And the fact that they are already postmenopausal, they do have a low, they have bone pain, joint stiffness, and all that. And now giving letrozole further actually makes it even worse in 30% of the patients. So this is not a simple thing to overlook. Treatment itself sometimes is not innocuous, and it can cause some problems. And the other common thing that people really assume is normal. It's not normal, it's fatigue, and we really need to address it. There's treatment-related fatigue, there's stress-related fatigue, and it's really the most common symptom among patients with breast cancer, and it's a major distress on both the patient and the caregivers. Fatigue also can result from the tumor itself taking a toll on you. You have a low blood count, or even the treatment taking a toll on you, such that you even develop low blood level in terms of hemoglobin, which again present as a fatigue. Or even brain metastasis, where you just do not differentiate between fatigue and altered mental status. So in that paper by Nathan Chani and team, this is the table that they talked about, on the non-pharmacological approaches to treating fatigue. You really need to plan your energy, because you really have a low energy reserve. So you need to do, planning of daily activities, prioritizing what really matters, leads to, low level of fatigue. And then energy restoration strategies is very important, where you make sure you need to get good hydration, good nutrition, and rest. And physical exercise, the more you move, this has been shown to really help with reduce the level of fatigue. Breathlessness, I think this goes without saying, very common, and one of the most common causes of breathlessness or difficulty in breathing in patients with breast cancer who have a spread of disease either to the lung, So there's so many causes. There's something called pleural effusion, where there's water, or discharge, or as you see the picture on your left, the X-ray is showing the right side of the lung is completely white out because of the picture that you see on the pink. There's pleural effusion, fluid building up between the pleura and the space. And if you look at the table on the right, it tells you most of the common causes of breathlessness or difficulty in breathing and the treatment. Things like pneumonia, antibiotics will do, for pneumonitis, a bit of steroids, pleural effusion, you can tap that fluid out, and maybe even if there's extensive endobronchial tumor, sometimes there's endobronchial laser, which probably is not even available in our setup. If there's congestive heart failure resulting from backup of this fluid into the heart, then there's a role for diuretics or the management of similar to heart failure cases. Delirium and confusion is really another physical pain for our patients with metastatic breast cancer or even in local advance. This could be, defined as an alteration in attention and awareness fluctuating in severity across time. It's a common complication of advanced cancer, and the incidence is actually of delirium and confusion is as high as 43% in the general population and 85% in patients with terminal. So that's almost double. And these are also different subtypes of delirium, and this really needs to be addressed. Sometimes these, might require the input of a neurologist or a physician to really see exactly what's going on. And some patients actually present with delirium and confusion as a presenting symptom. I've seen a couple of them as with a metastatic breast cancer, and you do a head scan of the brain, either MRI or CT, and you see lesions all over the place. Okay, so this should not be looked, it's something that can really present even as an initial symptom. Depression, I think this is very key to talk about, as a symptom, common symptom, and maybe well underreported by a lot of patients, because culturally there are people who do not even understand what depression is in their own culture. They just think you're stressed. That's how it's defined. I'm just stressed about life and financial and disease. So this really needs to be addressed and needs to be even screened. We need to screen patients for pain management, depression, social, like issues, family issues, cost of care of cancer. All these should be like a checklist in every visit for these patients, okay? And depression can be further exacerbated and even caused by the treatment the patient gets. For example, corticosteroids, hormonal therapy, and whole brain radiation for someone probably who has, brain and spread of the disease. Once you do whole brain radiotherapy, that also messes up further the cognitive level and leads to, a bit of a depression or altered mood. Okay. And these are some of the symptoms, as you are aware. There are people having alteration in their mood, something called ruminative or negative thoughts like suicidal ideation and all that, passivity, where they're totally, disengaged from usual activities, or the more fancier time is anhedonia, meaning not finding happiness in doing things. Okay, these are all symptoms of depression and poor sleep pattern. So, and this probably is, should be also initiated again, as I said, by multidisciplinary, either a physician or a neurologist can be brought on board, or even a medical officer, to making sure that antidepressant, if diagnosed, maybe should be started, and psychotherapy also by a skilled therapist or medical counselors should also make sure. But there's one thing to note: in patients with breast cancer, those who are taking the drug called tamoxifen, we need to be careful with the drug-drug interaction. So there are a couple of drugs that are used for treatment of depression, like SSRIs, like fluoxetine and paroxetine. These actually might lead to accelerated the metabolism of tamoxifen and might be passed out to the kidneys quickly, so it might not be affecting its role. And this tamoxifen is an anti-estrogen drug used to control cancer, breast cancer. So if it is excreted quickly, it might not do its job, because the other drugs that you are concurrently taking with tamoxifen might increase its metabolism and excretion. Now, coming back to narrowing down to the common challenges of palliative care in breast cancer, specifically in our setup of humanitarian setting and rural community practice, I want to really emphasize again on these fungating chest wall tumors. Again, it would have been really nice to show a picture of that. The initial management of this should include proper debridement and proper wound dressing, and regularly wound dressing, and to avoid infection. When there is oozing from the lesions, topical hemostatic agents like jungle juice. This is just a term we used to use during internship. It's basically a concoction of normal saline, couple of percentage, I think 20%, and then you add a bit of adrenaline. You add, vasoconstrictors, and then you use that to sort of like, to manually achieve hemostasis of the wound. Another approach that has been described is use of ghost saturated adrenaline. It's a bit similar to that. Dressing changes will often require pre-medication. There are people who have really terrible wound, and you can't just rip it off like that. You need to make sure if actually it might even require a short, sedation, and just by the bedside, or even a proper debridement in the operating room. So this really cuts across from simple pain, which can be relieved by oral morphine or tablets, to actually doing a proper dressing in the operating room. Brain metastasis is very common, as I've mentioned. It's actually around 15%, of the patient with metastatic breast cancer have brain involvement, and the risk of the brain, metastasis is very low apparently in hormonal subtype, but it's very high in triple negative and HER2 positive. Remember the three subtypes that I've mentioned: HER2 positive, hormonal subtype, and triple negative. Triple negative and HER2 have a higher predilection to spread to the brain. So depending on the subtype of the breast cancer, you need to make sure you're asking your patient about the neurological symptoms. This include headache, confusion, or a new onset convulsions. Okay. Treatment, this includes, from supportive care to radical treatment, supportive or conservative management include use of steroids, which help with reduce the edema or the swelling of the brain. You could start with around 10 to 20 milligram and taper down slowly. And to as aggressive as doing whole brain radiotherapy, or even sometimes what we call metastatectomy. If it's just one single lesion in the brain and it's causing a lot of problem, you could actually just do surgery by a neurosurgeon. And there's also a role for lapatinib and capecitabine. These drugs are believed to cross the blood-brain barrier to initiate some bit of activity against the disease for HER2-positive breast cancer. I think this is very important. Opioids I've mentioned, and we know we appreciate the lack of access of opioids in refugee communities or even humanitarian setting. But this is really, really a right for many cancer patients, especially those with advanced breast cancer or any advanced cancer disease. And this must be titrated from this effective smallest dose, and then you titrate upwards, not the other way around, okay? And you need to also to be very cognizant of the adverse effect of morphine or opioids general, such as drowsiness, confusion, nausea, itching, myoclonus, and or constipation. So we should not just give the drug, and we should anticipate and accordingly educate the patient on the side effect, and they should report back all the side effects. These are summative, supportive care resources. Bone metastasis. So it's divided into basic setting, which means maybe in like humanitarian or refugee setting, limited setting, which has somewhat of facilities to take care of this patient, enhanced setting, which is like top tier hospitals, and maximal setting is where everyone wants to be treated if they are able to be treated. So for bone metastasis in our setup, probably making sure NSAIDs, the drugs are given, opioids is available. And then for bowel obstruction, make sure, because morphine causes constipation, you're given laxatives, and it also causes a lot of nausea and vomiting, so make sure you give antiemetics. For brain meds, make sure you're using steroids and anticonvulsants, liver capsule or liver metastasis drug therapy, or even pain medication similar to the ones above. Lung metastasis, which causes breathlessness, opioids, oxygen, all these should be given. And skin metastasis complication or chest wall fungating mass resulting from the breast, wound care assessment, as we talked about, and topical, hemostasis achievement is also important, or simple barriers, and topical antibiotics as well. I think I'm coming down to the last few slides. Palliative care resource allocation. This is also very important in terms of the first one is, if I go back, was talking about the supportive care, resource allocation, which is organ-based, site-specific. But this one is, pain management and the end-of-life care with metastatic disease, the resource allocation. Again, similar, there should be pain management, which is addressed very well. If you look at enhanced setting, like I was talking about, people have actually access to pain, an opioid pump where they can actually, control their own dosage and everything. They get something called fentanyl patch or methadone. They get to have an expert or a specialist of pain therapy or a surgical fracture obstruction, decompression surgery if there's a spinal cord spread. I think the other important thing, which is very poignant to our setup, is the psychosocial end-of-life care discussions and spirituality, the role of spirituality and goals of care. Psychosocial is very important according to our culture. Patient and family caregiver should be, educated about the disease and bereavement support, and even preparing patients actually for an impending death. Having such a discussion can be very difficult in African culture. But I think sometimes if the patient really is cognizant of, it has a good insight, and the family has a better insight of the disease, it's good to discuss goals of care and not to be too aggressive in the last few months of life at the expense of, toxicity and no any value-based care or no survival gain. Spirituality is very important. There are people who use spirituality as a coping mechanism, especially I know of Muslim community or even a lot of African community or culture have their own spirituality because of their own view of death is very important in regards to their spirituality. Okay, so it's very important. It's a tool that can really help you in shaping your goals of care with the patient that is in front of you. Finally, the conclusions are that patients with advanced breast cancer and their families have complex needs. These are very important, and they're even more poignant in the humanitarian setting. When unmet, it can result in severe distress and undermine their quality of life. So it's very important to really treat the patient and their family holistically together. Optimizing the quality of life and well-being of these patients and their families require a meticulous approach to supportive and palliative care. And this goes without saying, multidisciplinary approach to palliative care with strong emphasis on the assessment of needs and anticipated needs, and the availability of scaled therapeutics and commitment to continuity of care is very important. And this is the point that I will mention again: patient assessment, family assessment, healthcare professional assessment. Those three should be really your go-to plan whenever you institute and you want to help any patient with advanced care. And finally, I think all that I've talked about, we may not have all those stuff that I talked about in terms of care, but I think Garissa Referral Regional Cancer Center is open to the doors of the public patients and refugee communities. We do have radiotherapy, we have chemotherapy. At least for radiotherapy, we could even use it for somewhat like patients who have fungating tumors, which are really refractory to all kinds of pain, and it's still oozing pus and everything. Radiotherapy can play a big role in the pain management. Chemotherapy the same way, pain medication, palliative care nurses that we have, and medical social workers. Thank you very much. That's all.
Thank you so much, Dr. Omar, for a great discussion about really identifying what are the diseases that we will see, what are some of the issues. And I am really curious, our numbers have increased, so up to 30 participants. I'm curious if there's any questions from the group. Dr. Omar was quite honest in sharing and kind of empathizing with the rest of us, knowing that we don't necessarily have access to advanced treatment. Most of the patients we will see in humanitarian settings have advanced disease. But he is available, and he's been very consistent with our group. He's supported us, wants to see patients and their families getting the best care possible. Does anyone have a specific question or something to be clarified from the discussion today? All right, Annalise, go ahead.
Yeah, good afternoon, everyone.
Hello, Annalise.
Mine is just maybe, okay, it is a concern.
Yeah.
I wanted to ask Dr. Omar to go for chemo at the cancer center.
Yeah.
And then, after the first or second dose, they come back to the camp. And then it becomes difficult for them to get another referral to Garissa again for the next dose. So could there be any plan that maybe they can send for them their drugs or what? I don't understand, because one could be sent for drugs by relatives from Garissa, and then we get it difficult, and they end up now dying just without finishing their doses. It becomes a problem. I don't know how best he can support us to make sure they finish their dose, and then the follow-up system. I don't know.
Yeah, really good question.
I hear you, Annalise. That's a very common problem that we've seen. But I feel like that stems from the whole legality and the logistical, services that are available for refugee communities. I've even seen cases that really want to go to Nairobi and for a PET scan, for example, or for further treatment, but they cannot go because of most of them are undocumented immigrants, which is really sad. Access to healthcare should not be really pegged on legality issues. But what we have seen few experience with the team, with the Red Cross, I think used to coordinate. They've been very kind to help few patients, but I don't know if if that extends further to everyone. But you should understand that there's a lot of, their hands are a bit tied because they support some of them. But again, you know, it's just mostly it's just the legality issue and the paperwork and the documentation of these patients. But at any given point, I think if they come to Garissa Cancer Center, the problem is who will cater for their cost during that period of treatment, because sometimes they can go as long as every 3 weeks they need to get one treatment. You can imagine for 6 cycles, that's like 18 weeks. 18 weeks is almost like 4 months, 5 months, right? And if they were to stay in Garissa, which is fairly a cheaper place to stay, but again, it's very costly for an immigrant. It's not as, it might be cheaper than Nairobi, but still, if they don't have the logistics and even just, you know, getting the right document to stay in Garissa while they're getting their treatment is a problem. So I think there's need for UNHCR, or I don't know, you know, the Red Cross really to have a memorandum of understanding and a logistical support with the county government of Garissa. I might not be an expert in those, but I think if there was a proper standing memorandum of understanding between the two for specifically refugee communities and, you know, patients who are like very poor, then it will have been really nice. Or maybe they help with their lodging and their boarding and even their treatment. But it's mostly more of a push and pull between the documentation and the legality, but less so on the availability of the drugs, in my opinion.
What are your thoughts, Dr. Omar? Do you think ever that chemotherapy could be given in the camp, or do you think that's just too far?
Yeah, no, I think that's a bit dangerous, because chemo can be very dangerous in the hand of an untrained person.
Yeah.
So it cannot be given. I've never heard of in advanced setting, as I was talking about basic and enhanced maximal setting, there are people who probably have such services in their home, but I have not seen that happening in Kenya. And if it was to happen, it has to be administered by an oncology nurse, at least, who knows what they're doing. It has to be in a controlled environment. In case something goes wrong, you need to be having a standby with your drugs. So it's very dangerous, I think, to go. And we would have loved to do that, but chemo is very tricky and it's very dangerous. Should be given in a controlled setting. So I think working on how to really improve access for these patients to such a nearby facility, you know, it's not even as far as Nairobi. It's very close to Dadaab, is very close to Nairobi, to Garissa. But I think it's just the refugee legal mechanism, and the county government of Garissa just needs to have a plan. I don't know who can advocate for that. But we in case you need our support, we're happy to write a letter or something. We're happy to do it.
So Annalise, not a great answer to your question, but I think Dr. Omar is on our side. As you guys continue to work, Annalise is one of our very committed and palliative care nurses, and she's also one of the faculty on our team. And she sees day in and day out many patients that come that don't have access to basic treatment for cancer. And I think that's probably where her question is coming from, wanting to get the best care for her patients. And I think, Annalise, we continue. I know that it's not easy to continue in these situations, to continue to be the person that has to take care of patients when you know that now Garissa Cancer Center is nearby. But we keep on it. If you ever get invited to very important meetings, please let them know that Dr. Omar is on our side, and just keep at it. You've got 30 plus people behind you. And I know for sure at IRC, there's quite a big turnover. We had a very good connection with the recent medical officer at IRC, and her posting is now finished. And this is kind of the reality in humanitarian healthcare. People like Ali and Annalise, who stay in a role for many years, is quite rare. So we do obviously want to continue to build into them. But yeah, we just keep at it. But thank you for asking the question, Annalise. Unless we ask the question, Dr. Omar doesn't hear these questions. He also, I'm sure, will heed this in his other high-level meetings when he gets invited to those, and continue to share that there's big gaps. We are running out of time. I feel like we could be talking about these things for a long time. But so we want to move to the case. And I know Dr. Omar needs to leave shortly. But if you do have time, Dr. Omar, just to stay for a little bit, and then love any comments related to the case, if you could share in the chat. For those that are on the call, if you have further questions to Dr. Omar, we can send them on to him. But please do put it in the chat or put it on our WhatsApp group, and we'll pass that over. So I do want to introduce now one of our other faculty members and very committed palliative care providers. Her name is Vilma Oliveros, and she has been connected with PallCHASE Education Working Group for the last several years. She's currently based in Canada, and she's working with a few different organizations, one called GPS Health Navigators that looks at providing support to refugee patients in Canada who come to the Greater Toronto area and are looking for support specifically related to palliative care and people living with chronic illness. And she also has a private consultancy organization that she shared her website on, where she does some coaching, some teaching, as well as other things she focuses on. So please do check it out. Vilma has been very connected and supporting this program again for many years, and we're really grateful that she's going to share the case today. So over to you, Vilma.
Thanks, Erin, for the introduction. Can you hear me okay? Perfect. This is a case that was put together before, so I don't know the patient, but we're gonna work through it together. And if you have any questions, we're gonna leave them to the end, please. And we're gonna learn from this, hopefully all together. So the key questions, and we're gonna focus on this while I go through the presentations, is what are the causes of this patient's suffering? How can we support young patients with severe symptoms when we have limited resources? And how can a palliative care approach or support help this patient and her family? So, patient details. This is 35-year-old woman who has been diagnosed with advanced metastatic breast cancer to the bone, liver, lungs metastasis. And remember, she's 35, and currently she is at home, and some care has been done by the community team. She has a fungating wound, which, by the way, they were mentioned by the doctor. I had never seen one, but I Googled the picture, which, I mean, I can just imagine how hard that must be. And it is on the anterior chest wall with a foul odor. She also has spinal cord compression, which was also mentioned by the doctor. And this is due to the metastasis. And it is a late presentation, so when she found out about the diagnosis, she wasn't even able to receive any oncological treatment. Now, the holistic assessment, which is what the doctor was talking about, it includes only, pain and symptoms, but also we focus on all the other areas, right? So the pain, she's currently having pain in the chest due to the tumor infiltration in her back, due to the bone metastasis. She also presents breathlessness due to lung metastasis and possible PE clinical diagnosis, which I'm not sure what that means, Erin, so you're probably gonna have to say that to me. Poor sleep due to the pain and loss of mobility. So she is bedbound due to the spinal cord compression. Low in mood and anxious about her health, probably depression, as the doctor mentioned too, right? So the diagnosis was just shared with her 2 weeks ago, very recent. She's a refugee from South Sudan, arrived at Abdihamid in 2015. Her husband died before she fled from her country. She had 8 children. 2 of the children died in South Sudan. Currently, she's caring for her 5, 7, 9, 11, 14, and 15-year-old children. She has 2 brothers in South Sudan, and her brother-in-law wants to inherit her. She is Muslim, and her religion is very important to her. She has found strength and hope in her role as a mother and cope with the loss of her husband and 2 children by caring for her other children. She does not know why this is happening to her. She's questioning her faith, right, in God, why he allowed this to happen, and she's afraid of what will happen to her children after she dies. So in summary, a 35-year-old South Sudanese refugee in Uganda with advanced metastatic breast cancer, severe uncontrolled symptoms, poor prognosis, bedbound with increased pain and fungating wounds, social and spiritual concerns related to her situation. So going back to the questions and the ones at the beginning, and now is the time for discussion, right, Erin? So do you want me to leave the questions here?
Yeah, we can. Yeah.
Okay.
Some people usually put on the chat, but if others are interested in engaging directly, Dr. Omar may not have a ton of time. I know he has to head to his clinic. So I don't know if Dr. Omar wants to give a quick thoughts.
No, I'm here. It's okay. Yes, thank you, Vilma, for this nice. I like the way you started with the questions, you ended with the questions. So that's very good. It's such a a common case that we see every day. But it's even, if you could go back to the first, I don't know, the one that talks about her social life, where she's from and all that. The one that I was talking about.
This one?
Just click on that. Yeah, okay. Yeah, so she's very young. Can we just focus on that, to be honest, 35 years of age. That is not just a number. That's a very important number to note in terms of such kind of a disease presented. So this is not this is not a disease of the elderly, as many people think. We see more and more young women, and being diagnosed with a disease like this. Have you mentioned if there's any family history at such a young age, her sister, or that information was not available? It's okay. So that's that's also important to note. But look at this. This is what we call de novo or upfront metastatic breast cancer with large, visceral crisis or large volume disease, as we call it, because it involves the bone, which is the most common, as we talked about, the liver, you can imagine, and the lung metastasis. So this is like all this stuff that I talked about. So I think now going back to your question, Vilma, if you can go to the final question, or I think it was, so what can we do? I mean, what are the causes of these patients' pain and suffering? I think number one is, we can say, physical pain, emotional pain, family pain, and even existential crisis, right? Those are like really the main facets of suffering for this specific young patient, and also low socioeconomic status and her being alone. You said she lives with, I'm sorry, Vilma, I'm taking you back and forth. What was her family like, family structure? Is she living alone with her children? There's a slide you talked about her children. So she's okay.
Give me 1 second. I think the previous one, this one, she has
exactly.
Now she has 6 children that she's caring for, right? And that's a big concern for her.
And she's a refugee from South Sudan, but her husband died, so there's already clear lack of support in terms of someone really to even care for her and her children together. And she's fled from her country. So this is like classic. She has 5 children, actually 6 children. She has 2 brother-in-law wants to inherit her. Can we mention that as well? So these are all unique, and cultural nuances that we really need to talk about. Whatever you make of that last statement might be even a bit lower compared to the other problems that she has. Okay, so I think again, going back to those 3 facets: family assessment, patient assessment, healthcare assessment, right? She, as a patient assessment, you can see she's really the right candidate for multidisciplinary care, to really address both her social, psychological, spiritual spiritual, because religion is important to her, as it's been mentioned. And in terms of family assessment, you can see all these family dynamics. Her husband died. Brother-in-law wants to inherit her. She has two brothers who are not with her, if I get this correct, because she's in Uganda, right? And you know, she's a refugee of all that. So all these labels really are working all against her, and it is what it is. This is someone who really has requires high level of concerted effort in her care. But and again, coming back to the final question slide, Vilma, I think what can we address for her? You know, what is her pain? We talked about her pain: physical, mental, stress, social, everything. How can we support young patients with severe symptoms when we have limited resources? So again, number one, I think early referral to a nearby center will really be the top priority here. So I don't know which is the nearest facility that she can go to. Her disease is quite spread. Was this because it was seen in a CT scan, or how did you guys know she had all this spread of a disease? Was there some form of imaging that was done?
I know in
Yeah,
Uganda,
I'm not sure.
Yeah,
Yeah.
I know in Uganda the system's a little bit different. So although it's quite remote, they do have access to the public healthcare system. So I'm wondering if she did have
Okay.
access to a basic
Okay.
scan.
Okay, that's
Yeah.
good. Yeah. So how can we support young patients with severe symptoms when we have limited resources? I think we can really make do with what we have. Top priority is not even treating the cancer up front. If you already have a problem like this, is first of all sorting her support base in terms of family and healthcare support that she can access to. Number one, on top of, before even that, is to really improve her quality of life and address her pain needs. You know, you can imagine if you have a lung metastasis or lung spread, you probably have breathlessness, I've mentioned. So she's going to need to be taken care of that, either by taking her to a facility that can do tapping, where they can remove that water and she can feel better when breathing. In terms of liver cancer, as I've mentioned, I'm sure she has that severe abdominal pain. So this could be even a breakthrough pain. So she needs to get a proper pain medication sorting that. And the other thing was bone metastasis. This is very critical. She has an impending risk of even developing a fracture, because the disease grows into the bones and makes it very weak. And you're not very lucky if that bone that is involved by the disease is the one on the back, you know, because that's where it's your like central gravity, where you hold your weight. So you see a lot of people getting fracture related. We call them pathological fractures resulting from, you know, the disease involvement. So I think, you know, pain medication. And you might ask me, is there a role for chemo actually for such kind of patient? Depending on the disease spread, if she had only one disease site, let's say like only liver, but she was able to walk, she's not bedbound, and she can be walking, and she doesn't have any like lung spread. She only had what we call oligometastasis, meaning like only one site of disease spread, like the breast and the liver only. Really, she is still a candidate. But again, we don't give chemo to everyone. So the performance status of these patients already, you said, is bedbound. So you're doing more harm than good than actually doing chemo. And even if you're thinking of chemo, it's not the first thing to do, probably later if she comes up. But again, that is just on case-by-case basis. How can a palliative care approach support help this patient and her family? I think, you know, bringing on board her family and actually asking them for their insight about her diseases is very important. Like I told you, there are families who don't even know what the patient has, and there are patients who, you know, there are family members who want the patient not to know their diagnosis. That's a culture over here, you know, it's quite common. And you might think that is a bit outdated, but it's not. It's coming from the point of care for this patient, that they don't get stressed to find out about their disease. Like, oh, don't tell them. If you tell them, they're going to go down, they will not even, you know, eat for days and stuff like that. So I think in a nutshell, pain management is top priority here. Avoiding, you know, further progression of this disease is also important, but that can be attempted in different ways. Like now here, the bone pain, There's a role for radiotherapy, palliative radiotherapy to the back, where, I mean, I don't know where the bone lesion is, but depending on where it is, there's a role for radiotherapy. There's a role for drug called zoledronic acid, which helps in bone. It's a bone modifying drug. There's a high level of pain management, which also takes care of the bone pain. And then there's a need for, if there's the patient really is having a bone disease in the back, so then they should be wearing something called like a lumbar corset or a lumbar belt to help them stabilize their weight. And they need to really have an all-round care, which I'm sure she might not get it, but all these things are really important. So I think it's not about just treating the disease per se in terms of survival benefit, but it's also living good quality of life as well.
Yeah, thank you so much, Omar, for that. And can I say something? Like when you mentioned I really like that you mentioned the word or the concept of existential pain, because usually when talking about holistic, we're focusing on that, social, spiritual, psychological, but existential, really, it encompasses our lives, right? And for her, I mean, as a mom reading this, and I can only imagine the suffering that comes from knowing that she's going to leave now all these 6 children behind. And really from 5 to 15, it's not even, not even the 15-year-old could be responsible for all the others, right? It's not like she has an adult one that could now take care of the little one. So I would say, besides focusing on the pain management and maybe the wound care, because that will be something that would be impacting her relationship with her children even, right? Like, coming closer to her when maybe she has the odor that it's not pleasant. And talking about some legacy, I've mentioned this before, like that can bring her peace, maybe even relieving her pain, but it's more like existential and spiritual pain, knowing that her children are going to be looked after, that kind of support, because even if she were able, or if we were able to take her somewhere for care at this stage, I don't even think that she would be going back home, right? So I don't even think she would consent to that, to be honest with you. So whatever we could do to keep her at home and enjoy the moments she has with her children, I would focus on that. But anyways, yeah.
Kind of interesting in these kinds of situations, and I'd love to give the floor to some others that are in the field. But it's really interesting in these cases because people that are often caring for these patients are nurses or physicians, which in palliative care, we are kind of cross-trained, right? On a lot of the psychosocial, the spiritual, but it may not be actually your most, the thing that you went into nursing or medicine for is to provide that kind of care. And I think after the session for today, with the teaching as well as the case that Vilma has shared, it really kind of shows us that we as providers need to be really ready for these kinds of situations, because it may not be that her biggest need is the medication. It may be the psychosocial support that is needed, and we might be the only one, that's interacting with her and her family that needs it. There's been some really interesting comments in the chat related to total pain, total suffering. I know previously in our sessions, we talk a lot about sitting with suffering. It's probably will be one of the most uncomfortable situations that we as human beings can be. Yet if we don't sit with the patients, sit with their family, really understand what they need and what we can give based on our limited resources, I don't think we'll be able to care for the patients well. Philippine has shared losing a husband, having to leave their home country, the physical pain, are all really very serious. Again, linking the patient to a support group would be really important too. In South Sudan, the Bang is sharing the patient is facing so many challenges, but the most difficult one is making her worried about her children. And again, it's the social, it's the spiritual, the psychological that in basic humanitarian settings, we may have one social worker for an entire hospital. So would she get access to that person? Maybe not. And I think that's why we come together in these kinds of situations on a monthly basis to support you in the work that you're doing, to give you some resources, but also just to be here, to listen, to say together that these are quite common cases. These are not easy. Bang, do you want to share? I know that you and your team often care for patients like this. How do you guys manage these cases?
Yes, good evening, or maybe good afternoon or good evening. Yes, how are you?
We're good.
Yes, are you getting me now?
Yep, yep.
Very good. This case, based on what I see, it is a very difficult case, but in some extent, but the culture can contribute a lot, because in some point you may find maybe if a lady lost her husband, she may be suffering to take care of the children, yet when it comes maybe to become, when children become an adult, like maybe girl will be married, boy will get married. So those who were not participate, or those who were not contribute during that struggle when your husband got lost. So it is difficult also. Yeah, it is difficult also, because that's why you see this lady, she was worried about her brother-in-law, because when, you know that if those little girl will become an adult, when it comes that they will be having something that they will be pawned from them, despite that she's the only one suffering to take care of them. Those who will not participate in this couple of time when their mother is suffering, they will be the first person who will get something tomorrow from those children. Yet they did not contribute in a term of financial, as they are suffering now with their mother alone. So that's the thing that can even also make the mother to be worried, because she knows that she was suffering alone, and yet tomorrow she will not be the only one who will benefit from those children. And again, as I put across before, that scenario, it is not the first time also to be seen, but there are so many people who had a chronic disease, like as we discussed this patient. So in some extent, you may find you may suffering alone, but as I mentioned, the most serious one, it is the issue of children, because the way she was suffering with the children, if she lost her life today, then she may be worried about her children, because he said, when I left, my children will not be okay, because they are suffering even if I'm around now. Then the other one is about the Christianity, because I see the mother, she's a Muslim. So to convene, or maybe to help the mother on how she can also take care of her children in this couple of times, she may be having a need of addition of church leaders. So they can even also went to her home, maybe pray together with her, so convene her, bring the history, how she can be, for how she can be there maybe for that couple of times before in that period of time. I know it is very difficult case. It is very difficult case, but there's no way how we can manage. So in a term of financial, in Africa, let me say, in Africa as well, but people are talk maybe to help themselves, but they do nothing. So even if they see you are suffering, as even if you have one of your relatives who have some resource, he didn't care about you or her. So she may be just focusing on her life or his life instead of you, even if you see that you are suffering with that sickness of yours. So she cannot help you in a term of maybe giving you some money that can make you to go to a hospital, or maybe give you something that you can sustain the life of children with. So just she depend on him or herself instead of supporting you. So I hope it is a difficult case, but to support her, the church leader need to be involved so that they can advise the mother accordingly.
Yeah, thank you. Thank you, Bang. Just to confirm and echo that these are very common in settings where the social, once a patient has been diagnosed with a very advanced disease, the social issues often take precedent, and we need to be equipped to support them with their psychosocial concerns. Again, we sometimes are caring for people that are from a different culture, right? In these situations, this was a Ugandan nurse caring for a South Sudanese refugee. So she may or may not know the culture. She may or may not know the religion. She may or may not understand the family dynamics. So all these things are quite important when we're supporting patients in this way, and can really impact the future of her children and her family. And it does take time. It does take investment. Yeah.
The other part also in Uganda, as this case was present in Uganda, even also the patient is in Uganda.
Yeah.
But I know, but most of South Sudanese families are staying in Uganda. Some of them are in Ajimani, Yala, Arua. So I know, but the most also the other most difficult part also for her to be think or to be worried about also the term of education in Uganda also sometimes it's good, sometimes it's not good. But you may find he was struggling alone, maybe going to the farm to cultivate so that he may get some money that can let our children to go to school. And yet also she didn't manage to support them in the term of education also. Is also one of the factors that can even also make her to be worried, because as long as she's her lost her life, she may know that children may drop in the school, there'll be no more food, no one will support them in South Sudan. So because everyone is depending on his or her life instead of depending on somebody else. So it's also one of the factors that make her sickness, or maybe make her to be worried, so that he knows that he will not get any support from maybe from South Sudan or maybe within Uganda. Yes.
For sure. Well, I do see that we're kind of coming to the end. Dr. Zippy, do you want to make any final comments? I know that you're in a bit of a rural spot.
No, thank you. This has really been a good session from Dr. Ari's presentation to the case study. I think this is really a good case because it really shows us that there's so much that can be going on in somebody's life, not just the physical illness, but this is a lady who is in a refugee camp. So even just being displaced is the biggest problem, one of the biggest problems she's going through. It adds to all her other pain. And so I think it's a good example for us to learn from. And I know that there are many challenges for us to provide best care for such a person in a very difficult situation. But like we always say, there's always something that we can do. The counseling, the being there for the patient, trying to use whatever medications we might have available for pain, or for any other thing that needs to be treated. I think it's just it's very complicated, but yeah, thank you very much for sharing today's case, and also for the session on breast cancer. That was also very educative. Thank you very much.
And there could be times when you're faced with a patient like this and you personally are having not such a great day, and you just don't have the ability to provide the compassionate care that you are very motivated to provide. So please don't feel alone in this. Of course, we through technology connect, on a regular basis, but reach out to a colleague. If there are times when a case like this feels very overwhelming, reach out to a colleague, reach out to one of us on the chat. Sometimes you can be very motivated to give the best possible care after a training session like this. And then you get to work and you're like, there's nothing I can do. Like Dr. Zippy says, we teach in palliative care, and we know that we can do something. Maybe it's not what you hope to do, or maybe it's not what you really had planned for this patient, but what can you do? And that does take not just one person. You will burn out if you try to care for such a complex situation by yourself. Vilma, do you have any final thoughts? We're close to the end.
No, I just want to say I'm reading some of the comments here and talking about educating, like it says something about providing training to the community workers.
Yeah.
We've talked about that before, the peer support model too, right? Trying to empower the community and teach them how to support in that social, emotional aspect so they feel comfortable doing it. And that's something that maybe we can look at again and see if that can be provided. So
yeah, actually next month in August, we'll be talking a little bit about end of life and home-based care. So we'll make sure that when we cover that topic, we also talk about how to train someone who maybe has less medical or nursing training than you might have, but how it can really benefit the patients and families to kind of disseminate that information. I know IRC in Dadaab often does community-based trainings for community health workers, which has been really effective because on the IRC team, they're just a few people, so they can't really make it to all the home visits. So they've had to really work with that model. Yeah, it's really important. Okay, so just a reminder, we have the feedback form. The session for today is over, so thank you everyone for coming. We are meeting again August 20th, and we'll be talking about end of life and home-based palliative care in humanitarian settings, which can look very different in different contexts. But we're really glad that you're with us today, and I'll be sending around the reminders. If anyone does have a case that they would like to share, I know Ali is currently set up for August, but we have some space in September for our session. So please let us know if you'd like to present a case, and we'll see you next time. Thanks, everyone. Bye-bye now.